acute respiratory distress syndrome. The onset is usually within 1 week of a known clinical presentation or new or worsening respiratory symptoms. For chest imaging, whether radiograph, CT scan, or lung ultrasound, it usually shows diffuse bilateral opacities, which is not fully explained by volume overload, lobar or lung collapse, or even nodules. Taking into consideration the origin of pulmonary infiltrates, pulmonary edema may not fully be explained by cardiac failure or fluid overload. We may need objective assessment like echocardiography to exclude hydrostatic cause of infiltrates or edema if no obvious cardiovascular risk factor is present. For oxygen impairment in adults, patients with mild acute respiratory distress syndrome usually present with a partial pressure of oxygen or fraction of inspired oxygen as PaO2 or FiO2 in between 200 mm mercury and 300 mm mercury, with PEEP or CPAP greater than or equal to 5 centimeters water. The PEEP is positive end expiratory pressure, and the CPAP is continuous positive airway pressure, or even non-ventilated. For moderate acute respiratory distress syndrome, the partial pressure of oxygen or fraction of inspired oxygen is usually between 100 mm mercury and 200 mm mercury, with positive end expiratory pressure greater than or equal to 5 centimeters water, or even non-ventilated. For severe acute respiratory distress syndrome, the partial pressure of oxygen or the fraction of inspired oxygen is usually less than 100 mm mercury, with positive end expiratory pressure greater than or equal to 5 centimeters water, or non-ventilated. When the partial pressure of oxygen is not available in the SpO2, that's oxygen saturation, or the fraction of inspired oxygen is less than or equal to 315, it suggests acute respiratory distress syndrome. Even in non-ventilated patients, for oxygenation impairment in children, use partial pressure of oxygen based metric when available, and if PaO2 is not available, you win FiO2, that is the fraction of inspired oxygen, to maintain SpO2, that's oxygen saturation, that's less than or equal to 97%, to calculate the OSI, which is oxygen index using SpO2, or even the SpO2 FiO2, the fraction of inspired oxygen ratio. On non-invasive ventilation, that's NIV, BiPAP or CPAP greater than or equal to 5 centimeters water via full face mask, that is the PaO2 or FiO2 less than 300 mm mercury, or SpO2 FiO2 less than 264. For mild acute respiratory distress syndrome, non-invasive mechanical ventilation, the OI, which is oxygenation index, is usually between 4 and 8, or the OSI, which is oxygenation index using SpO2, is usually between 5 and 7.5. For moderate acute respiratory distress syndrome, non-invasive mechanical ventilation, the OI, the oxygenation index, is usually between 8 and 16, or the OSI, which is the oxygenation index using SpO2, is usually between 7.5 and 12.3. And for severe acute respiratory distress syndrome on invasive mechanical ventilation, the OI oxygenation index is usually greater than or equal to 16, or the OSI is usually greater than or equal to 12.3.